2000 WHO and Chinese. Amongst all these, you can see 130 by 80 is most of the societies what they have recommended as a normal cutoff. Or most of the societies they have given class 1 level of recommendation and level A evidence, level of evidence A. Except 2021 WHO, they have recommended 140 by 90 in all hypertensive patients without comorbidities, and 2022 Chinese guidelines, they also recommended less than 140 in patients, older patients more than 80 years old. Rest of all the societies they have recommended 130 by 80 as a cutoff target for blood pressure control. Now, what are the goals of management of hypertension? The aim or the goal is to decrease the blood pressure to less than 140 by 90 in patients with hypertension plus diabetes or the renal disease. BP goal should be less than 130 by 80. And another aspect is to reduce the CVD complications, cardiovascular, renal morbidity, mortality. This should also be our aim. Means optimal management of hypertension includes both pharmacological interventions as well as non-pharmacological interventions like lifestyle. Similarly, implementing early preventive measures means minimizing complications associated with hypertension. If you see the challenge of uncontrolled hypertension in our society, it is very big. Almost 40 to 50% patients of those hypertensives, they have uncontrolled hypertension. Means 50% means half of those patients with hypertension established diagnosis, they don't have their blood pressure under well control. So this uncontrolled hypertension can be a pseudo-resistant hypertension, it can be a resistant hypertension, or it can be secondary hypertension also. Pseudo-resistant hypertension can further be divided into white coat effect, inaccurate BP measurement, medication non-adherence, or under treatment. Resistant hypertension is very rare, only 2 to 5% of the cases you get this, and secondary hypertension also is not common. Example includes pheochromocytoma, renal artery stenosis, and certain endocrine disorders like Cushing syndrome, hypohyperthyroidism. So these are the causes of secondary hypertension. They are only 3 to 5% amongst all the total hypertension spectrum. There is one entity called difficult to control hypertension. It is seen in older age diabetic and CKD obesity patients, and they represents a very mixed group of patients with target organ damage and CV or renal disease. Now, if you see the treatment strategy, core drug treatment strategy for uncomplicated hypertension, so the initial recommendation is combination of either ACB, ARB, CCB, and diuretic. You can select any two drugs among these three. Nowadays, AC inhibitors we rarely use, so we will consider only ARB whenever it comes to AC or ARB. ARB should be considered practically. Then CCB, diuretics. When you want to combine, you can either combine ARB with CCB or diuretic. Second option or step 2 is you can combine all the three, ARB, CCB as well as diuretic. And blood pressure, if it is uncontrolled with this combination, it can be labeled as a resistant hypertension. Then you need to add spironolactone in the dose of 25 to 50 milligrams. Or even you can add alpha blocker or beta blockers also. For beta blockers, certain indications are there which I will be telling later. Same thing shown differently in this slide. First, you begin with either ARB single drug. If you want to combine, the blood pressure is more than 140/90, you can combine ARB with CCB or diuretic. If the blood pressure is uncontrolled, then you can combine all these three, ARB plus calcium channel blocker, diuretic also. Even if the blood pressure is uncontrolled, you can confirm the confirm the diagnosis of resistant hypertension, and you have to exclude pseudo-resistant hypertension and secondary causes for hypertension. Simultaneously, also you have to reinforce patient for lifestyle modifications like salt restriction, moderation of alcohol consumption, dietary improvements, weight reduction, regular aerobic exercises, smoking cessation, and C for the sleep apnea if appropriate. Even if the blood pressure is uncontrolled with three drugs, then you can add spironolactone or other diuretic, alpha blocker or beta blocker. Beta blockers, they are recommended only in compelling indications. There are certain indications for beta blockers like heart failure, chronic coronary syndrome, atrial fibrillation, and sometimes in women when they are pregnant or about to conceive pregnancy. If you see the recommendations by the various societies for these combinations, almost all the societies, ACC, AHA, ISS, WHO, Chinese even, they have recommended the same these three class of drugs in combination. Almost level of class of recommendation 1, level of evidence A. Only International Society of Hypertension, they have suggested to begin with angiotensin receptor blocker plus calcium channel blocker in a low dose. Then if the blood pressure is uncontrolled, then dose can be increased. Even if the blood pressure is then uncontrolled, then you can add diuretic to it. Then finally you can add spironolactone. Rest of the things more or less common. You have to select from these three drug classes. When you want to talk about selection of antihypertensive drug in certain special population, for those patients who have coronary artery disease, angina in particular, so recommended drug is beta blocker and calcium channel blocker. Class of recommendation 1, level of evidence C. Those patients with prior myocardial infarction, beta blocker or AC inhibitor, ARB. Class of recommendation 1, level of evidence O. C. Those patients who have heart failure, they have the option of HFrEF, means heart failure with reduced ejection fraction or heart failure with present ejection fraction. ARB, angiotensin receptor neprilysin inhibitor, ARNI is recommended. Class of recommendation 2, level of evidence B. Prior stroke, AC inhibitor, diuretic or combination of both. TIA, calcium channel blocker or ARB. You can see beta blocker is not recommended as first line choice in neurological problems. So only in cardiac problems you can prefer beta blockers. In diabetics you have the option of angiotensin receptor blockers and SGLT2 inhibitors. SGLT2 inhibitors and also GLP-1 RAS agonists. SGLT2 inhibitors and GLP agonists, they are basically anti-diabetic drugs. Still they have been used in cardiac failure problem and they have been also recommended for the management of hypertension also as antihypertensive drug also. CKD patients with microalbuminuria, renin-angiotensin system inhibitors, and those without microalbuminuria, same renin-angiotensin system inhibitors. If you see the two classes of antihypertensive drugs acting synergistically, they could help to significantly improve the outcome. Like the same thing, if the blood pressure is uncontrolled with single drug, you can add another with CCB. If it is uncontrolled, go on adding telmisartan or ARB, go on adding diuretic, like that. Now coming down to molecular mechanism of calcium channel blocker. So we will not go into the detail of this slide. There are three types of calcium channels available on the cell membrane: voltage gated calcium channel, receptor operated calcium channel, stretch operated calcium channel. Our main importance, our main focus is on voltage gated calcium channel. They can further be divided into L type, T type, N type, P type and R type. So this L type, the main targets of our calcium channel blockers is L type. They are present in cardiac myocytes, smooth muscle cells of the vessels and endocrinal cells. T type of receptors or calcium channels. They are present in neurons, endocrinal cells, conduction system of our heart, pacemaker, atrial cells and Purkinje cells, Purkinje fiber cells. They have T type of channels, and NPR type of channels. They are present in neurons like neurons of the brain and pituitary gland. Excuse me. If you see the problem with the conventional calcium channel blocker, so they had the problem of reflex tachycardia and there was much incidence of pedal edema with their use, and they don't have any role to play in elevated proteinuria level. So we need to look beyond the conventional CCBs to control, to tackle these three issues for carrying our heart and kidneys. So for the controlling the gateway of cardiorenal disease with azelnidipine, a newer molecule which acts on both elevated aldosterone level as well as elevated blood pressure level, acts on our heart and acts on our kidney also. So this azelnidipine, which is a novel CCB, here you can see three type of channels, graphic representation, L, N and T type. This nifedipine mainly blocking the L type, amlodipine also L type, and this nifedipine and amlodipine L type, cilindipine blocking the N type, and this our azelnidipine and efulodipine. Efulodipine, they both block L as well as T type of receptors, which is clearly seen in this diagram. We will talk now. Our focus will be azelnidipine. You can see here, it is a new dihydropyridine calcium channel antagonist, and as I said, it is a L and T type of calcium channel blocker, composed of a racemic mixture of containing a 1:1 ratio of active R enantiomer and the inactive S enantiomer. Now, what are the effects of blocking these channels on the various organs? So, if you block L type receptors, they on the heart they will cause decrease in the contractility. On the sympathetic nervous system, they will increase the pulse rate. On the kidneys, they will have increasing the glomerular pressure effect. When it comes to N type, blocking the N type channels will reduce the heart rate, will decrease the pulse rate, will decrease the glomerular pressure. Same things will happen with the T type blockage. So our azelnidipine blocks N and T type, both these receptors, thereby producing reduction in the heart rate, reduction in the blood pressure, and reduction in the proteinuria. Also, in addition, azelnidipine has reduction in the aldosterone secretion. So this is the unique or enhanced effect with azelnidipine you get, which other CCBs they don't have much. Here you can see multifactorial action of azelnidipine, blocking L type and T type calcium channels in the heart, resulting into reduction in the heart rate and resulting into the vasodilatation. It has 17-fold higher lipophilicity than of amlodipine, so definitely this drug should be preferred. Also, this molecule blocks the T type receptors present in the afferent arteriole, thereby reducing the intraglobullar pressure, reducing the proteinuria. Also, this drug azelnidipine blocks the T type of calcium cells which are present in the zona glomerulosa of the adrenal gland, inhibiting strongly aldosterone synthesis and release, thereby avoiding all the toxic effects of the aldosterone on the body. One more beautiful effect this molecule has, which has a negative effect on the SA node, inhibiting the T type calcium channel activation leads to prolongation of the late phase for depolarization, causing the reduction in the heart rate. So these were the actions of the azelnidipine as far as various organs are concerned, and I have said various other unique effects of azelnidipine also. Now there are certain studies which are present in the literature regarding azelnidipine. We will review certain studies. We will only focus on their main features. So first study is the study in which azelnidipine is compared with amlodipine, and their effect is observed on the chronic morning hypertension and home pulse rate control. Here you can see those patients who have received azelnidipine. There you can see significant reduction in the systolic as well as diastolic blood pressure, and also a significant reduction in heart rate. Heart rate was greatly reduced in those patients who have more than basic basal pulse rate of more than 70. In them, 8.2 minus heart rate reduction was noted, as against only 3.8 with amlodipine. So these findings suggest that azelnidipine may be useful antihypertensive agent for patients with morning hypertension. Second study, it has shown the effect of azelnidipine on the carotid arterial hypertrophy, which is a strong independent risk factor for the cardiovascular morbidity and mortality. Here you can see a 6-month therapy azelnidipine effect on the carotid wall thickness in the form of, there are two markers of assessing carotid arterial thickness. One is pulse wave velocity, another is intima media thickness. So you can see greater reduction in both. Both are arteriosclerotic markers, pulse wave velocity as well as bilateral intima media thickness. Both were significantly reduced after a 6 months azelnidipine administration. So this is how it has shown its effect. Similarly, there was one study by the name of Aorta was conducted, in which azelnidipine was combined with olmesartan in one group, and this olmesartan was combined with amlodipine in another group, and their effects were studied. after 12 weeks. So total number of patients were 50. For the first 12 weeks, all patients they received olmesartan in 20 milligram per day dose. Hypertensive patient, BP more than 140/90. Then the patients were randomly assigned either to azelnidipine 16 milligram OD or amlodipine 5 milligram OD. 25 patients in each group. They were studied further for 24 weeks. Their central blood pressure and left ventricular mass index, they were measured after the at the end of the study. So these were the findings. You can see olmesartan azelnidipine had greater effects on central blood pressure and LV mass index than did olmesartan and amlodipine. So these differential effects on central blood pressure and left ventricular mass index may have important implications definitely for cardiovascular risk reduction. So this was very important study by the name of aorta study. It was published in Vascular Health and Risk Management 2011. This study actually it is a compilation of various around 14-15 studies. It was a Chinese study in which around 14 studies were combined. Approximately 600 patients were enrolled. All they have mild to moderate hypertension. All the patients they received azelnidipine in the dose of 8 to 16 milligram for a period of 8 weeks to 12 weeks. All have noted significant reduction in blood pressure in these Chinese patients. It has been seen with mild to moderate hypertension. In addition to antihypertensive effect, azelnidipine had other protective effects as well on the heart, like antioxidative action, decreasing heart rate and improving systolic diastolic function. And this molecule was very well tolerated in all the Chinese patients, and there were no severe adverse events except 1 or 2% of the patient they had headache, flush, edema and palpitation. Only 1 to 2% patients. So its efficacy was confirmed in this study. How much safe it is you can assess now. In this study, they have studied the antiarrhythmic effect and the improvement in the cardiac sympathetic function with this drug azelnidipine. You can see total number of ventricular extrasystoles after switching to azelnidipine compared to that of amlodipine were drastically reduced. Similarly, washout rate of 1231 MIBG scintigraphy before and after switching to azelnidipine was decreased. What this shows? This shows ECG decreased significantly after switching to azelnidipine compared to that during amlodipine treatment, and the washout rate decreased significantly from 23.4 during amlodipine treatment to 18.4 after the switch to azelnidipine, suggesting that cardiac sympathetic function was also improved in the azelnidipine group. Similarly, the free radical 8 isoprotein was significantly decreased, while antioxidant adiponectin levels were significantly increased after the initial treatment with this drug. After switching from amlodipine, azelnidipine significantly decreased heart rate and the total number of extrasystoles also. NORAD level and the low frequency to high frequency ratio, which is a marker of autonomic influence over the heart, sympathetic ratio we call it, significantly gone down, and the washout rate was significantly reduced to 1231 on 1231 MIBG myocardial scintigraphy. Finally, azelnidipine inhibits the enhancement of sympathetic nerve activity and the progression of arteriosclerosis through its antioxidative effects. Now, in this study, effect of calcium channel blockers on glucose tolerance, inflammatory state and circulating progenitor cells in non-diabetic patients with essential hypertension was studied as compared to amlodipine. So this drug azelnidipine, when compared with amlodipine, the heart rate after azelnidipine administration was significantly lower. 120-minute glucose levels were also significantly lower. CRP level, interleukin 6 level, circulating number of hematopoietic progenitor cells after azelnidipine administration is significantly higher. So results suggest that azelnidipine treatment may have beneficial effect on glucose tolerance in diabetic patient, insulin sensitivity, inflammatory state and number of circulating progenitor cells in non-diabetic patients with essential hypertension. Again, confirming its usefulness in metabolic syndrome and obese diabetic or pre-diabetic patients. In this study, famous by the name of PART2 study, balloon versus Atherotomy Trial 2, full name of this study. In this, maximum carotid intima media thickness were reduced in azelnidipine group but not in amlodipine group. Here you can see azelnidipine group representing decreased reduction in the intima media thickness, whereas there was no effect with amlodipine group. Similarly, the inflammatory markers like tumor necrosis factor alpha, monocyte chemoattractant proteins were significantly reduced in azelnidipine group. So azelnidipine delayed the progression of carotid atherosclerosis, which was not observed with amlodipine, and this action was mainly due to reduction of the inflammatory markers like monocyte chemoattractant proteins and tumor necrosis factor alpha. So this quality is shared by only azelnidipine, not by amlodipine. In this study, they have shown how azelnidipine can cause reduction in the aldosterone and cortisol. We can see aldosterone secretion from the H29 5R cells was suppressed in a dose-dependent manner by all calcium channel blockers, and the effect of azelnidipine and efimidipine on the secretion from these cells were more potent than that of nifedipine. Here you can see release of cortisol was much lower as compared to amlodipine and nifedipine. Slightly better reduction with efimidipine. Azelnidipine, so therefore, my friends, is a promising antihypertensive drug for the treatment of aldosterone involved in cardiovascular and renal diseases. So this calcium channel blocker, they have all the calcium CCBs. They have the same antihypertensive action. They have they have vast difference in their pharmacological action, their pharmacokinetic profile, and their adverse actions. Amlodipine is safe, gold standard, effective drug of choice in chronic hypertension due to its slow and prolonged duration of action, low cost, and lesser incidence of reflex tachycardia. But it has a big issue of pedal edema. So and also the blood pressure lowering effect of amlodipine and other new drugs is not vast. Means the difference is not that significant between other newer CCBs and amlodipine, BP reducing effect. So the novel CCBs differ in their lipophilicity, vascular selectivity, pharmacodynamic properties, anti-systemic action, anti-atherosclerotic action, renoprotective action, neuroprotective actions. The incidence of baroreceptor activation and pedal edema was also found to be lower in the newer calcium channel blockers. Hence, the new generation calcium channel blocker could be preferred for various cardiovascular problems. In this study, they have shown how azelnidipine has protected the myocardium in hyperglycemia-induced cardiac damage. This treatment with the azelnidipine significantly reduced the level of troponin I, CK-NAC, LDH, CPK-NB, uric acid, alkaline phosphatase. Also, reduction in the various inflammatory markers like tumor necrosis factor alpha, elevation in the level of interleukin 4 were observed. A significant decrease in the serum cholesterol, triglyceride, and significant rise in the level of good cholesterol HDL was also observed. Means a better positive effect on the lipid profile was seen. Azelnidipine corrected the disordered or distorted antioxidant enzyme profile, resulting in a significant decrease in the level of lipid peroxides, nitric oxide, and carbonated proteins. So this azelnidipine treatment can reduce the risk of hyperglycemia, induced metabolic disorders, and its role can be further extended to explore its therapeutic potential in diabetic patients with cardiac complications. When it comes to comparing with the 4th generation CCB, because azelnidipine is a 3rd generation CCB, when you compare it with cilnidipine, so both cilnidipine and azelnidipine, they provided at par comparable BP and heart rate lowering effects. As such, there was no difference. But in those patients who have heart failure with preserved ejection fraction, when they are shifted from cilnidipine to azelnidipine, they tended to have low levels of brain natriuretic peptide and could reduce and they can reduce in that group. It has been shown that neurological dysfunction in the cardiac sympathetic nerve activity was less. So azelnidipine could reduce in a better manner dysfunction in the cardiac sympathetic nerve activity and the level of brain natriuretic peptide in those patients of heart failure who have preserved ejection fraction. Azelnidipine proved to be better molecule than cilnidipine in this regard. So my dear friends, hypertension is considered in our Indian context. The prevalence of this disorder is very much high in our country in both middle-aged and older individuals. amongst all socioeconomic groups, the prevalence among the younger individuals is underreported. Actually, it is higher than previously estimated. This is especially concerning since this disease can significantly influence patient's quality of life. This disease is a major risk factor for cardiovascular disorders, metabolic syndrome, diabetes, CKD, all of which are also highly prevalent in our society. Patients and clinicians across the country, they should benefit from an agent that provides antihypertensive effect in individuals both with and without additional comorbidities and protect against the development of cardiovascular, metabolic and renal disorders. So when you see the advantages of azelnidipine in Indian context, clinical data available clearly suggests that azelnidipine is suited to fulfill this role. Like many other countries around the world, friends, India is experiencing a population aging process with the number of older individuals expected to almost double by 2050. It is really a problematic thing. This will contribute to an increase in definitely the number of burden of non-communicable diseases such as hypertension and its hypertension related comorbidities, cardiovascular, metabolic and kidney disease. So this azelnidipine has a variety of beneficial effects in addition to BP lowering effect. In the currently used CCBs for many clinicians in India, azelnidipine appears to be an appropriate, effective and well-tolerated alternative for the holistic management of hypertension. To summarize the things, azelnidipine has been approved for use as an antihypertensive agent across the India. This molecule has several advantages over the current CCBs of choice in India, that is amlodipine and other agents in this class. Benefits beyond hypertension control, allowing holistic management of hypertension and related disorders such as cardiovascular disease and metabolic syndrome. This molecule has benefit on reducing plasma harvesting levels, 24-hour BP control, including early morning surge, heart rate, and has negligible incidence of edema. The evidence summarized here provides a good rationale for the adoption of this molecule azelnidipine as a first-line antihypertensive in India. So, such a shift toward the use of this molecule in India could substantially help in the country's fight against the hypertension epidemic and improve the quality of life in the patients in the long term. Thank you very much. Thanks.
Thank you so much, sir.
Over to you, Shahzad now.
Yes, sir. Thank you so much. Now I'd like to